This presentation was given at a think tank on problem gambling treatment systems integration, held by Gambling Research Exchange Ontario, GREO. Rod Olfert, Senior Integration Officer at the Champlain Local Health Integration Network, presents Integration in Ontario's LHINs. Rod Olfert is a Senior Integration Specialist with the Champlain Local Health Integration Network, co-managing mental health and addiction files in the region. He also manages the orthopedics file, centralized access, and the development of the Champlain Orthopedic Network. He has been with the Champlain LHIN for just over 3 years. He previously worked as a knowledge broker with the Canadian Centre on Substance Abuse and Addictions and mental health counselor in the community sector, and trainer and educator in Ottawa, the Yukon, and Manitoba. Rod still works in a private practice with others in Ottawa, with a focus on youth, young adults, families, and concurrent disorders. Beyond orthopedics, Rod's current focus at the LHIN includes the expansion of centralized access for mental health, addictions, and concurrent disorders, improving the transition for youth from children and youth services to adult services, implementing evidence-based screening and assessment tools with service providers, and integrating primary care into the addictions and mental health sector. Rod serves on the Provincial Mental Health and Addiction Systems Planning Committee, Coordinated Access Work Group, and the EENet Steering Committee. He believes strongly in integrated, holistic, and systemic approaches to health service delivery and client care. This video has been professionally narrated based on a presentation made by Rod Olfert at the GREO think tank on problem gambling treatment systems integration on January 24, 2017. My name is Rod Olfert, and I'm a Senior Integration Specialist with the Champlain LHIN. LHIN stands for Local Health Integration Network. LHINs are regional organizations that are responsible for planning, integrating, and funding local healthcare within their region. There are 14 LHINs across the province of Ontario. The Champlain LHIN covers an area along the Ottawa River, from Deep River to the west to Hawkesbury to the east, including the entire city of Ottawa. It's a very exciting time for LHINs right now, as integration is happening on a lot of different levels, and I will explain what we mean by integration in the context of the LHINs in a moment. It's an exciting time for healthcare. It is changing, and we are going to provide some examples here from the governance, financial, and from the service delivery perspectives on these integrations. These are some of the highlights we'll be covering in this brief talk. The Patient's First Act, or Bill 41, and its impacts on integration. Sub-regional planning and the integrational opportunities that emerge from that. This is a huge change for the LHINs that we'll discuss further. We will look at the development of a Provincial Mental Health and Addictions Leadership Advisory Council and the integration strategies that we're attempting in various areas, screening and assessment as an example. We'll talk about the Healthlinks model, which is a very strong integration model across sectors. And we'll discuss these two strategies as well, PSSP, or Provincial System Support Programs, with the GAIN tools, and the Ontario Perception of Care tool, which we call OPOC. This is taken from the Champlain LHIN website. It gives an idea of the number of service providers and the number of health programs we're responsible for delivering, monitoring, managing, and being accountable to. What does integration mean in this context? We have what we call regional integration, as well as integration at the sub-regional level, as we are dividing our LHIN into 5 sub-regions in order to manage our health systems better. Provincial integration, which involves activities like making some screening and assessment tools available across the province. System integration, involving the integration of mental health and addiction providers to improve service delivery coordination across these 2 important areas. Sector integration. Structural integration may involve bringing 2 organizations together, for example, to be structurally integrated. It may be a financial governance arrangement. And what we have often done with the mental health and addiction service providers in Champlain is to functionally integrate them into a continuum of care. For example, service provider A provides service to complex clients. Where will they go afterwards? Service provider B should have integrated services so that there is a smooth transition from one service to another, or a smoother transition from one funding of services from the Ministry of Children and Youth Services, MCYS, to a LHIN-funded organization, as an example. Bill 41, the Patient's First Act, is changing the landscape for the LHINs, and I will put out a couple of highlights here. The Patient's First Act came into legislation December 8, 2016. One of the most significant changes for the LHINs is that there is now some oversight of primary care providers, including physicians, to support collaboration between the LHINs and primary care providers. We haven't had that kind of authority or relationship before, and it has been an area of difficulty, So this is a good change. Anyone who has been a client themselves or supporting a family member who needs multiple services in the healthcare system will understand how difficult it can be to bring a physician into a continuing care plan for someone who may need access to services in mental health and addiction services, for example. And we hear this from our primary care advisory council as well. They want to know how they can access these mental health and addiction services for their clients. A second significant change will be placing a stronger emphasis on French language services provision as a model of care that promotes equal access. To clarify this point, the LHINs will not have directive powers over local hospitals in terms of supervision. The LHINs will take on a more active role, which is yet to be defined through the patient's first act. There is, of course, a lot of discussion around the implication of changes on privacy from the Health Information Protection Act, Bill 119, so we want to assure people that client files and identities will be protected. This slide provides a little more on integration in our particular context. The LHINs have not had an integration of this proportion since they were created in March 2006. Community care access centers provide a range of specialized care to clients in their homes and communities, including physiotherapy, nursing, speech therapy, and palliative care. With this integration strategy, Cc Acs are coming under the financial governance and authority of the LHINs. So for the first time, the LHINs will become service providers, when up to this point, the LHINs have traditionally been the funders of service providers. Other opportunities may exist with Cc Acs as well. For example, how the LHINs will bring the Cc Ac resources into Healthlinks to strengthen coordinated care plans for complex populations, and perhaps scaling up the Healthlinks model of care, not just for the top 5 or 10%, but to other populations as well. We will look at how we will bring the Cc Acs resources into service delivery to serve clients and communities better. We will also consider integrating the Cc Acs into the LHINs health information services, something that has been missing. This slide lists some of the services provided by Cc Acs. The LHINs have been working in partnership with the Ministry of Health for some time to be able to integrate, coordinate, and collaborate with service providers in a much more concerted way. The concept of sub-region planning is part of achieving that. For example, the region of Champlain goes from Cornwall up to Deep River and down to North Grenville. It is a very large geographic area. The LHIN may struggle to keep its finger on the pulse of the needs across the entire service area. However, the local service providers certainly have that grasp on their client base. The vision is to take the regions that make up one LHIN, in this case we are looking at the Champlain LHIN, and divide them up a little bit more. And this will make it easier to coordinate smaller groups across sectors and systems to deliver better care. Many things will remain the same, however. For example, clients will be able to access their own primary care physician even if that physician is in another subregion. The subregion model will help the LHIN and our funded health service providers deliver service in a more strategic and local way that reflects the unique needs and challenges of those particular communities. So now, rather than having planning tables with primarily mental health and addiction providers, you might also have someone there from the Cc Acs, the physicians groups, and the community support service groups, all at that same planning table because now they are responsible collectively for the healthcare service delivery for all people in the subregion. It's a more focused and holistic approach. There has also been a strong integration approach to mental health and addictions, primary care, and other services working more closely together. This slide lists the 4 goals of the mental health and addictions 10-year strategy. This slide details each of those 4 goals of the mental health and addiction strategy. This provides a sense of some of the province's priorities put forward by the ministry, and the LHINs would certainly agree with all these needs. Problem gambling, which is our key subject area for this presentation, is included in this integrated approach and strategy. These are some proposed areas of focus for the mental health and addiction strategy moving forward: prevention, promotion, and intervention, primary care, and justice, because we're talking about high-risk populations of adults and kids. Stemming from the provincial work, there has been the creation of a Patient and Family Advisory Council, PFAC. PFAC is composed of professionals, patients, families, and people with lived experience to advise government on health priorities that have an impact on patient care and experiences. In the last couple of years, the LHINs and mental health and addiction leads within the LHINs have been working more closely together than ever before on common areas that affect every LHIN and every community. It has been a challenge at times in terms of resources to achieve the outcomes we are hoping to achieve in service delivery for clients. For that reason, we have landed on 3 work group streams. Primary care work group. We want to make sure that we have very strong integration and co-service delivery and to share care among the whole health system, ensuring primary care is available to those accessing mental health and addiction services, and vice versa. Coordinated access group. There is currently coordinated access for some healthcare services and through local service providers, but historically, there has not really been a coordinated access for mental health and addictions. We have some good models now, including one in Champlain for addiction services. If there was better coordination in these areas, the LHINs could be doing a much better job, for example, of identifying problem gambling and other risk behaviors. Supportive housing work group. These vulnerable populations we are talking about have housing needs as well, so we've created a housing work group, and we've seen the province make some investments into this area in recent years, and will likely continue to do so. We try to bring those mental health and addiction supports to these vulnerable populations. Healthlinks is perhaps the most current and well-known integration model. The hope is for LHINs is that this Healthlinks model will become the standard of practice for healthcare at the sub-region level in the future. The concept of the Healthlinks is to improve the client journey by providing coordinated, efficient, and effective care, screening, and assessment to truly understand their needs and to bring a model of care with professional service delivery and appropriate supports for those needs. Some existing Healthlinks have achieved those results. This is some data from the Healthlinks report that is in the public domain. This shows the relationship or partnership between the Ministry of Health and Long-Term Care, MOH-LTC, the LHINs, and Health Quality Ontario. There is still work to be done, but there has been an integration of funders, service providers, quality and improvement folks with the goal of delivering better care. These are some statistics on Healthlinks according to the last quarterly report. 96 Healthlinks are planned and 84 are actively recruiting at the time of this report, with that number growing. The numbers in red show a great success, as it has been a challenge to reach the targets that all the LHINs want to reach. The number of coordinated care plans in place as of the end of this report is impressive, because that number would not have been as high previously. This indicates that the LHINs are in fact bringing providers together, including a primary care physician lead in each of those health clinics to deliver service in a much better way. These next few slides tell Margaret's story. Margaret is a client who was homeless and had significant challenges in her life. She joined a HealthLink, which was able to capitalize on the resources available in her region, including a community care access center, the Center for Addiction and Mental Health, and the Salvation Army, to bring a coordinated system of care to meet her needs. There are a lot of Margaret stories in HealthLinks from every LHIN, and it's very rewarding to see the difference these coordinated systems can make. This is some additional data around the success of HealthLinks, coordinated care plans, and improved primary care delivery, broken down by each of the 14 LHINs. These are some integration models that we have seen some success with, and we have to acknowledge the efforts of provincial organizations like CAMH, Center for Addiction and Mental Health, and the Provincial System Support Program, PSSP. This integration project has already been successful and is still in progress. The overall model and the collaboration and integration expertise has been fundamental to implementing the accomplishments at the service delivery level in a way that will work in the long term. It is not just another screening or assessment tool. There was a full provincial rollout of the project that really led to its success. These strategies were developed in partnership with the Ministry of Health, addressing the LHIN's need for an actionable strategy. One issue we encounter is that people can be very resistant to change. For example, certain models of care may be working for individual providers and clients, so those providers may be satisfied with the status quo. But the lack of consistency across the system in terms of screening or assessment of substance abuse and mental health disorders has been a real challenge, because if we are not screening in an evidence-based way, and if we are not matching the right kind of service to the right kind of need, we are not being accountable to the funders, the taxpayers, and the clients we serve. The Screening and Assessment Project, or SSA project, has helped with this challenge. In Champlain, the LHIN has mandated that all addictions providers in the province use the GAIN suite of tools. The GAIN is the Global Appraisal of Needs, a widely used comprehensive biopsychosocial assessment tool. The GAIN has further been developed into several more targeted variations, including the GAIN SS for short screener, the GAIN Q3MI for motivational interviewing, which are the two tools providers are now mandated to use, further adapted by CAMH into Ontario-specific versions. An important finding when developing these projects was that for service providers, the most important requirement beyond the strong research base, which is essential, the real key in terms of seeing clinicians use a tool is for it to be concise and accurate. The GAIN SS is ideal in that sense, and the GAIN Q3MI is slightly longer, but is also concise. The success of the Screening and Assessment Project has been in getting provincial support to roll it out with the providers. The LHINs fund providers for service delivery. The providers are not expected to be knowledge exchange or evaluation experts. The LHIN funds the providers based on number of clients seen, number of visits, number of bed days. When another tool is introduced in a completely new data system, how does that get implemented consistently across the province? Even the LHINs are not in a position to be able to support that implementation across all providers. So the province has worked with CAMH and the PSSP teams and the LHINs to provide the resources to support the rollout, using an implementation science approach. The support provided LHINs with a regional coach who was responsible for training all providers, answering all the questions, navigating the software systems, troubleshooting when there are problems, and scheduling training seminars. They make sure the LHINs have certified regional GAIN trainers that can sustain the implementation and delivery of the tools into the future, expertise and resources that the LHINs could not have provided themselves, and the project would not have been successful had that support from the province had not been there. Integration is occurring now through this GAIN suite of tools, for example, with applications providers coming together, because traditionally even programs within the same organization may not have necessarily been integrated. Uptake has been very strong with our community service providers. There may be more challenges with the community health centers and with hospitals because they have multiple funders and multiple reporting systems. And hospitals will certainly say that they have been using their own evidence-based tools for some time now. There will be negotiations with some of these hospitals around what they have in place, whether it is similar, whether it can be moved. Those will be the next steps. Ontario Perception of Care, or OPOC, is another tool that will be integrated across mental health and addiction providers. The OPOC is a client measure, a client perception of care tool that will inform service providers and the LHINs about what the client's perceptions are around standards of care. This is very important information in terms of quality and improvement, and for providers to understand how clients perceive the programs that are being delivered to them. For both of these initiatives, the Screening and Assessment Project and the Ontario Perception of Care tool, there is a provincial database and support around the collection of data. This will allow the collection of data to get a sense of the client profile in the province, and not only by the province, but also at the LHIN regional level, and likely, because the LHINs will be further divided, at the sub-regional level as well. This has not been available before. This is a summary of the Ssa project, its objective, and projected outcomes. This is an overview of the GAIN SS, and, of note for the context of this presentation, in terms of the number of problem gambling questions, there is one in the original GAIN SS, and there is another one in the CAMH modified version. So there are 2 problem gambling items in the GAIN SS version being implemented through this project. This is another screening tool in the SSA, the MMS Modified Mini Screen, which is conducted as a Stage 2 assessment following the GAIN SS for adults. This is the MMS equivalent for youth, the problem-oriented screening instrument for teenagers, POSIT. This is an overview of the GAIN tool, the GAIN Q3MI, and specifically the Ontario version of the tool. And a few more points on the GAIN Q3MI here. Here are some of the domains that the GAIN Q3MI covers. This section covers the OPOC project. This may be one of the most important initiatives for the LHINs after Patients First, which in fact really led to this project. This is an overview of the OPOC project, its objective and projected outcomes. The OPOC's main purpose is to collect the vital feedback of clients. As part of the LHINs transformation, all LHINs will have to have a patient and family advisory committee in place. It's very important to hear the voice of clients and family members as early on as possible to generate the ideas that are needed. This will be a key element of this project. These are the domains covered by the OPOC, with some example questions. There are 2 versions of the OPOC, the client version for direct recipients of service, but it also includes what was previously called a family version, which is now called the non-registered version. That is for people who may come into a service without being formally admitted, such as a parent or child receiving service, and it asks them about their experience, not about their loved one's experience. The OPOC will help inform quality improvement, and this has been identified by Accreditation Canada as an approved instrument for assessing client satisfaction for accreditation purposes.